Good morning, everyone, and welcome again to another fantastic session of the ATS Journal Club. My name is Ayodeji Adegunsoye. I'm a pulmonologist at the University of Chicago with a special interest in the interstitial lung diseases. I'm also joined by my wonderful colleague, Dr. Carla Copeland, a member of our ATS Journal Club leadership, who is an outstanding pulmonologist from the University of Alabama at Birmingham as well. The topic for today is going to be centered around Nerandomilast, the blockbuster new medication in the ILD world. And it's going to be based around the New England Journal articles that were published in May of this year, earlier on. This will be presented by a fantastic panel of speakers today. We have Dr. Justin Oldham from the University of Michigan and Dr. Toby Maher, who comes to us all the way from the Keck School of Medicine in Los Angeles, California. And they will be discussing details about the publications, as well as addressing questions that we may have from the audience as well. I'll also start by thanking Danielle Robledo from the American Thoracic Society coordination team, who helped with navigating the Journal Club logistics and getting us together today for this presentation. So the way we're going to proceed today is we will start with a short presentation of the New England Journal papers by Drs. Oldham and Drs. Maher, and then we'll take questions from the audience as well as the panelists today. First, I'll welcome Dr. Justin Oldham. He's a pulmonologist from the University of Michigan, an eminent ILD physician, multiply funded by the NIH, and he'll start with the New England Journal paper today. Justin?
Yeah, thanks, Tej. Hi, everybody. Thanks for joining. So I've been tasked with discussing the Fibroneer IPF publication in New England, and then Toby's going to take you through the PPF paper. So there will be a lot of similarities, so we can try to not overlap as much as we can. But just background on these two studies, obviously we had 2 drugs approved for IPF leading up to this trial. We had 1 drug approved for PPF, being nintedanib, pirfenidone, the other for IPF. And during these last few years of disappointing phase 3 trials, a beacon of light emerged with a phase 2 trial of this drug, now called Nerandomilast, whereby over a short phase 2 trial, there was clear separation in FVC, prompting this drug to be taken to phase 3. And so I became involved in the program at that point. Toby had been long involved with this, so has an even better understanding than I do. But with regard to IPF, at least, with the 2 approved drugs, we saw that patients continued to progress. The drugs slowed the disease progression, but didn't stop it. And so we needed additional drugs to better slow the disease and hopefully stop the disease. And so this trial was a little different than the prior trials in 2014, which had truly treatment-naive patients. So this was now done in the new era of antifibrotic therapy and allowed background nintedanib and pirfenidone, which is important to contextualize these results. And so before I get to the breakdown of the study itself and the results, it's important to keep in mind that the criteria used to design the trial needs to be considered when thinking about this, for your patients. But the inclusion exclusion were pretty standard. Patients had to be at least 40 years, be diagnosed centrally with IPF, first by the investigator, and then the CT was reviewed centrally to make sure there was a UIP pattern. If the pattern was not UIP or probable UIP on the central read, then a biopsy had to accompany the patient, showing a UIP pattern histopathologically. So these patients were 40, had IPF by the investigator, was confirmed centrally, and then had to have an FVC of at least 45% and a DLCO of at least 25%. These were slightly more liberal than some of the prior trials that have been done, I think, which is welcomed by the community, just because we often see patients with very low DLCOs, and we want to offer them something, and moving that down to 25%, I think, was helpful. And then, as I said, patients could be on background therapy with nintedanib or pirfenidone. They had to be stable at least 12 weeks on these drugs. And if they were going to be considered not treated, they had to be off of these drugs for at least 8 weeks to be eligible for the study. So now getting to this figure here. So this is the disposition of these patients. So 1720 were assessed for eligibility. 500 plus were excluded mostly because they failed to meet inclusion or met one of the exclusion criteria. Of those, about 1,200 underwent randomization, and as you can see there, about 400 per group, of which the overwhelming majority completed the 52-week observation period. Those who didn't complete it were for a handful of different reasons, but again, overwhelming majority completed it, which is an early indicator of tolerability. So we can go to the next figure. So this is the baseline characteristics, pretty typical IPF cohort. As you'll see, there are 2 doses of nerandomilast that were tested. And I actually didn't even say what this drug does. This is a selective PDE4B inhibitor. And the phase 2 had 1 dose. This had an additional dose, the 9 milligram dose, to try to pick apart what the optimal dose was going to be. But 2 arms, 18 milligram, 9 milligram, and then a placebo arm with about 400 in each group, as I said. So pretty typical IPF cohort, predominantly male, mean age of 70, lots of former smokers, and then FVC about 78% predicted, which is a little higher than we've seen in some studies. DLCO is down in the 50% range, which is, I think, pretty standard. And then as opposed to other trials prior to this, we had, almost half of patients treated with nintedanib, 30+% in each arm treated with pirfenidone, and then about 20% in each arm that received neither drug. And then another marker of disease severity, of course, being supplemental oxygen, about 20% on supplemental oxygen in each group. So this is the primary endpoint. So like most IPF trials, primary endpoint was a 52-week change in vital capacity between the 3 groups. The study was powered to identify differences between each of these groups and placebo. And as you can see, a very clear dose-dependent effect from placebo to the 9 to the 18 milligram in the overall trial population, which is in the top left corner, A panel there. Those in the placebo group had 184 mil FVC decline over 52 weeks. Those in the 9 milligram had about 140, and those in the 18 milligram had about 115. And these were statistically significant in each group, and 70 mil FVC savings in the 18 and about a 45 mil FVC savings in the 9 milligram. So this being performed in the modern era of antifibrotic therapy, there's obviously a lot of interest in what happens in those who are either not taking or who are taking background therapy. And so the B panel is those who are not on therapy. And these patients had about a 150 mil decline, which is interesting because the early Impulsus and Ascend capacity trials showed more decline in the placebo group than we were seeing here, which we thought was interesting. Maybe a just holistic change in care is causing patients to have slightly less decline, but it was hard to pick apart why that might be. And then basically the same effect between the 9 and 18 milligram in this group relative to the placebo, but still, an impressive, almost 50% reduction in FVC decline in these groups. And then when we go to the background nintedanib group, we're now seeing about as much FVC decline as we saw in the early trials. And so this gave us an early indication when we first saw these data that these groups might be systematically different. And when I think to my own experience, the patients that we brought into this trial typically were progressing despite nintedanib or pirfenidone. And so a lot of us feel that you kind of have to view the on background therapy versus not on background therapy as probably 2 systematically different groups, which might explain why the not on background therapy group had a little bit less change in vital capacity over time compared to those who were on background therapy. But despite this probably being a more progressive group, you still see there is good treatment effect for nerandomilast compared to placebo, both at the 9 and 18 milligram dose when you are assessing background nintedanib. Little bit different story with background pirfenidone. So here we don't see any difference between the placebo and 9 milligram dose. We still continue to see an FVC savings in the 18 milligram dose, but I believe this is somewhere in the supplement. It won't be in this in the main paper here, but there did appear to be a drug-drug interaction between pirfenidone and nerandomilast, whereby those who were receiving pirfenidone had lower circulating plasma concentration of nerandomilast, and so that probably dropped the 9 milligram to a subtherapeutic dose, whereas the 18 milligram probably hovered down where the 9 milligram would be in the other groups. Um, so, despite the drug-drug interaction, there did seem to be a still efficacy in the 18 milligram dose. So we can go to the next panel here. So this is the secondary endpoint. This was, despite the enthusiasm of the initial primary endpoint, this was a little bit disappointing. The key secondary endpoint was a composite of death, acute exacerbation, or respiratory hospitalization. And as you can see here, there was essentially no effect of nerandomilast on this secondary endpoint relative to placebo. Hazard ratio is 1.17 for the 18 milligram dose, going in the wrong direction, and then 1.03 in the 9 milligram dose. It became a little bit more interesting when we broke down, these individual endpoints. And it's a little harder just looking at the data. We've got newer forest plots that I think show this better, but the acute exacerbation is a tough variable to measure. Hospitalization is probably even more variable. What's a respiratory hospitalization for exacerbation versus infection that's not exacerbating versus heart failure that's called respiratory. And so when we pick out these more subjective inputs into this key secondary endpoint and just focus on death, we saw something that was a little bit more promising, which was there was a numerical reduction in death in the 18 compared to the placebo, and a little bit in the 9 compared to placebo. And so this was kind of an early indicator that maybe there is a survival benefit with this, albeit not even close to statistical significance, but at least going in the right direction relative to these other components of the key secondary endpoint. And I will say there is a paper that is just accepted into the Blue Journal last week that used the full follow-up period. So this analysis here was performed once everybody had completed their 52-week visit. There was a second database lock where new analysis was performed after the last patient had completed their final study visit, which gave another month plus of cumulative exposure, or of mean exposure. Cumulative exposure was obviously a lot more than that. But what we saw was all these key secondary endpoints migrated to the left, especially death. And so the number of deaths kept going up more so in the placebo group than the other groups. And that paper will be out relatively soon, but the hazard ratio is going down to the 0.6 range, if I recall. And then, Toby will tell you even more compelling evidence from the PPF trial, but this was, I think, what most of us focused on from this trial, which was, the early first database lock. There was a suggestion of a mortality benefit, which became even stronger over time. And then when you pick apart, death or 10% FVC decline, which is obviously the strongest predictor of subsequent death, we see this also play out both at the first database lock and gets even stronger with the second database lock. So this is adverse events, and this is a busy table. I'm not going to go too far into it. Like every trial, almost everybody has some adverse event, but it was not any different between the nerandomilast 9 and 18 compared to the placebo. Diarrhea was the biggest concern, just because similar class for roflumilast had a lot of diarrhea. PD4D has a lot of diarrhea, and so we were all very interested to see what the class effect or individual effect from this drug would be. And in all patients, we definitely saw a higher rate of diarrhea in the 9 and 18 milligram of nerandomilast groups. But as I said before, a lot of these patients were on background therapy. And so when you break it down between those who are not on background therapy versus those who are, a lot of this diarrhea was being driven by background nintedanib. Because when you focus just on the no background therapy, which is the second group over there, granted not huge numbers, but we're only seeing about 25% of patients on the 18 milligram dose had diarrhea at 17% on the 9 and 8% in placebo. So not a huge increase over placebo. And very few patients stopped the trial because of diarrhea. I don't know if that one, yeah, here it is. So you can see down below, one patient in the no background therapy group stopped for diarrhea, but otherwise, very few discontinuations related to diarrhea in the trial. And then the rest of the adverse events I'm not going to go into just because there wasn't a whole lot of difference. I don't think it's on here, but there was no, it's not reported because it wasn't common enough, but there were no LFT abnormalities by and large with nerandomilast, which is obviously a stark difference with what we have had with nintedanib and pirfenidone, suggesting that we won't have to do any drug monitoring with nerandomilast, which on top of the efficacy data, I think makes a lot of us quite excited about this drug. So I'll stop there with the IPF trial, and then Toby can take us to the PPF, and then I think we'll have a good discussion after that.
Yeah, thank you very much, Justin. That was really a fantastic overview of the paper with you carefully highlighting the nuances that we should pay attention to. I think that was really important. A lot of the important aspects that I think we need to be mindful of in our clinical practice, you pointed out, particularly the efficacy results and the key endpoints of the study, just taking it all into context. And also thank you for highlighting the recently accepted Blue Journal paper for the end of trial results. I think that also provides additional context about the data. Given the longer exposure, you have more statistically powerful results. I think that's important for us to take into context. I think there are going to be a lot of questions from the audience. And so in the interest of time, I'm going to pass it on to Dr. Maher to go over the Fibroneer ILD study. It was published in the exact same issue of the New England Journal. And it also, I think he'll be highlighting important aspects that are similar or different from the Fibroneer IPF study that Dr. Oldham just presented moments ago. So Toby Maher is a professor of medicine. He's the director of ILD at the Keck School of Medicine, University of Southern California at LA. He spent the last 15 or more years just specializing in the management of patients with pulmonary fibrosis. He's the director of their ILD program over there, professor of interstitial lung diseases at Imperial College of London as well. And he's a British Lung Foundation professor of respiratory medicine. He's been involved in over 50 trials in fibrotic lung diseases from phase 1B through phase 4. He's recruited over 1,000 patients into interventional studies. He's given expert opinion to the FDA, to the EMA, and is an associate editor for the Blue Journal, the American Journal of Respiratory and Critical Care Medicine, and the editorial board of the Lancet Respiratory Medicine as well. In short, he's authored over 270 papers and book chapters on pulmonary fibrosis, and he's a perfect person to help us dissect through both New England Journal papers. So without further ado, we'll listen to Dr. Maher as he takes us through this exciting work. Toby?
Thanks, Deji. That was a very long introduction. It barely seems any time at all since we were all together in Chicago for the PFF conference last week, but nice to see you all on video as well. And by letting Justin go first, I've allowed him to do most of the hard work because the papers are very similar in many respects. So there's a lot that I don't need to say, given that Justin has just given us the background on PDE4B and a lot of the background on the trial design. So I'll go through this sort of reasonably quickly. I think everyone is probably familiar at this stage with the concept of progressive pulmonary fibrosis. It's a concept that's been around for at least 5 years, if not longer now, and really refers to patients who have fibrotic lung disease other than idiopathic pulmonary fibrosis, which has got worse despite, in some cases, treatment of the underlying disease process itself. And Justin and others have done very nice research showing that disease progression, once it occurs, actually trumps diagnosis in terms of predicting subsequent prognosis. So we know that progressive pulmonary fibrosis is an important cause of morbidity and mortality for patients with fibrotic lung disease other than IPF. And up until now, the one approved treatment that we've had for this group of patients has been nintedanib, although pirfenidone was tested in a couple of diseases other than IPF, it was never approved for any other indication. And so one of the initial differences between Fibroneer-ILD and Fibroneer-IPF is that the only background treatment that patients were permitted to be on was nintedanib. There was no background use of pirfenidone. So getting into the study data, this is the patient disposition. So this is a very similarly sized study to the IPF study. It is the same design, 2 doses of nerandomilast, 9 and 18 milligrams twice daily, compared to placebo. Patients randomized 1:1:1. So 1,700 patients were screened. Just under 1,200 patients were randomized equally to all 3 groups. And as Justin pointed out, the dropout rate was actually relatively low for a pulmonary fibrosis study run over 52 weeks. And importantly, the number of discontinuations was not different between the placebo group and the active treatment group, which is actually different to what we saw in the pirfenidone and nintedanib trials, where there tended to be more dropouts in the active treatment group driven by side effects. So this equality of dropout is already an early indicator that nerandomilast is probably better tolerated than pirfenidone or nintedanib. So let's move to the next figure. So the patient characteristics, I know just quickly, I didn't say the one other difference in trial design was that whereas for IPF, the minimum age was 40, in this, the minimum age was 18. Otherwise, the inclusion-exclusion criteria were very similar. Patients did have to have a minimum of 10% disease extent on CT as centrally adjudicated. And they had to meet progression criteria, which were the same as they were for the INBUILD trial, which are subtly different to the ATS guidelines. But patients had to have one of at least a 10% decline in FVC over the preceding 2 years, a 5 to 10% decline in FVC combined with either worsening symptoms or worsening radiographic appearances, or the combination of worsening symptoms and worsening radiographic appearances. And so moving on to the demographics table, again, not vastly dissimilar to the IPF study. There's a more equal gender split, so it was almost 50-50. So 55% male, 45% female. A fraction younger than in the IPF study, a mean age of 66 years. About 4.2 years since ILD diagnosis, and just over 2/3 of patients had a UIP pattern on CT scan. And the level of disease severity, again, similar to what we see in the IPF studies, mean FVC around 70% predicted, mean DLCO in the high 40s predicted, just over a quarter of patients on supplemental oxygen, and just over 40% of patients taking background nintedanib. So if we move on. Yeah, what also doesn't appear in that table, but which I will tell you anyway, is the background or the breakdown of diagnoses for the patients in the study. So just over a quarter of patients had autoimmune ILD, so rheumatoid, scleroderma, myositis, etc. And then just under 20% had hypersensitivity pneumonitis, just under 20% had unclassifiable ILD, just under 20% had idiopathic NSIP, and the remaining 10 to 15% had other diagnoses, things like IPAF, asbestosis, sarcoidosis, etc. And then this is the primary endpoint slide. So starting up in the top left-hand corner, this is essentially the primary endpoint for the whole population. We can see that similar to the IPF population, the rate of FVC decline in the placebo group is similar to what we've seen previously. So subjects lost about 165 milliliters over the 52 weeks. So very, very similar to what we see in the IPF cohort. And then we see this similar just over 40% reduction in the rate of FVC decline at the two different doses of nerandomilast. If we move to the top right, that's just looking at FVC change over time. And interesting to see that the two doses of nerandomilast are really indistinguishable over the 52 weeks of the study. And then we come down to the bottom two panels. So on the left-hand side are the patients not taking any background nintedanib. And you can see the rate of placebo decline. Again, like the IPF study, we have this slight paradox that patients not taking background antifibrotics have a slightly slower rate of decline than patients who were taking background antifibrotics. But the rate of decline in the placebo group on the left-hand panel is about 154 milliliters. Again, you can see the clear treatment effect. And then on the right-hand bottom panel, we have those taking background nintedanib. And here, the placebo rate of decline is about 180 milliliters. And again, that magnitude of benefit with treatment on top of background nintedanib is very similar. So as for the IPF study, the key secondary endpoint for the Fibroneer ILD study was a composite of respiratory hospitalization, acute exacerbations, and death. And the forest plot on the bottom part of this panel, first of all, at the top two lines are the key secondary endpoint, the composite. And then below that, we have broken out the acute exacerbations, the hospitalizations, and the death. And so I think there's a few things to take home from this. First of all, in comparison to the IPF data, the results for the secondary endpoint in the Fibroneer ILD study are actually much more striking. As Justin has said, the endpoint was actually to be measured over the whole duration of the study. Patients continued in the trial beyond 52 weeks until the primary data was available and until they could be rolled over into an open label study. And so this is sort of an interim analysis of the key secondary endpoint. The data for the full study were presented at ERS, and I'm expecting will be published in a respiratory journal very soon. And so this is sort of the initial look-see at the end of 52 weeks. And you can see that there's already a strong trend favoring nerandomilast that is more striking with the 18 milligram dose than the 9 milligram dose. You can see that the hazard ratio for the key secondary endpoint is 0.77 with bounds of 0.59 to 1.01. So it doesn't quite reach statistical significance, but it's very close. And then if you look at the different components of that, similarly, all of those come close to nominal significance. And I think the most important one is the one at the bottom, which is death. And it's worth pointing out a couple of things with this. First of all, the number of deaths in the placebo group was 12.8%. So it just reinforces how important PPF is as a problem. This death rate of 12.8% over 52 weeks in a subset of patients who are, fit enough to go into a clinical trial, who've met the inclusion-exclusion criteria. So we've excluded the most severe patients, and the death rate is still 12.8%. And importantly, treatment with nerandomilast almost halved the rate of death with a hazard ratio of 0.48 and bounds of 0.3 to 0.79, so reaching nominal statistical significance. And you can see the Kaplan-Meier curve in the top panel, just reiterating that point. And then if we go to the next figure, so we have the adverse event data. So again, this is very similar to the IPF study. I think the first point to note is that the number of adverse events were balanced across the groups, including severe adverse events and adverse events leading to treatment discontinuation. And then if we look at the breakdown of what was driving those adverse events, again, it was primarily diarrhea. And I would say, having now had patients in the phase 1, phase 2, and phase 3 trials for nerandomilast, I would say that the diarrhea is qualitatively different to nintedanib. Nintedanib, as everyone knows, the major problem tends to be fecal urgency, that once patients get the need to go to the toilet, if they don't get to the toilet very quickly, then often they will have accidents. I think with nerandomilast, diarrhea is much more benign. It really tends to be, if anything, a change in stool consistency rather than anything like the fecal urgency with nintedanib. Nonetheless, at the highest dose of nerandomilast, there was an increase in the rate of diarrhea compared with placebo. And when you look at whether patients were on nintedanib or not, it obviously is more of a problem when the drug is used in combination with another medication that already causes diarrhea, compared to when nerandomilast is used on its own as monotherapy. And actually, if you just look at the placebo groups, the placebo rate of diarrhea is only 15% in patients on no background nintedanib. It doubles to 36% in those on nintedanib. And then for nerandomilast 18 milligrams, it's about 26% on no background nintedanib, going up to 49% for those taking nintedanib. And then I think, as Justin said, for the IPF data, really there's nothing else in the table of significant interest. Pretty much everything else is balanced across groups, and certainly no liver function test abnormalities, which again is a key distinction with the existing treatments. So I think that takes us to the end of the paper. So in summary, nerandomilast met its primary endpoint in the PPF population. It came very close to meeting the key secondary endpoint at the initial analysis, and more data will be published in the near future. And the tolerability data looks very reassuring, with some diarrhea, but not much else as a side effect for us to be aware of.
Yeah, thank you, Toby, for that really beautiful and insightful presentation. I think, as always, it's always an impressive presentation that you deliver, and it's always crystal clear. So thank you again. We can begin to take questions from our audience, and I'll just encourage you all to feel free to type your questions or wave your hands to ask directly. Dr. Copeland is going to help oversee that aspect of questions, and she'll be assisting us with curating the questions so that we can get to them for our audience today. We'll start with our expert panel, and perhaps to get the ball rolling, I'll begin with a question that already came through. And it's also similar to one that has been on my mind for a while, which you probably have both heard of previously before today. So the first question goes to, I think, both of you, really. Given that we do have previously existing anti-fibrotic medications in the ILD landscape, which, based on their efficacy results, they both received FDA and EMA approval over 10 years ago. So does nerandomilast's efficacy in IPF and PPF, does that feel meaningful to you in the context of the data you just presented? And if so, why do you think it's meaningful? I'll probably start with Justin, put you on the hot seat.
Yeah, I mean, I think it's meaningful for a couple of reasons. One, we know that declining vital capacity is the single best predictor of future death, and any drug that impacts that is clinically meaningful. Two, we are seeing a early mortality signal here, which requires some contextualization and acknowledgement that it doesn't meet statistical significance. It does more so in the PPF trial, but when you take the two trials together, it's clear that there is certainly promising data regarding survival. So those two together definitely makes this drug something that is an advance for the field beyond what we've had over the last decade.
Toby?
Yeah, I think to add to that, I'm clearly nintedanib and pirfenidone have been incredibly important for our patients. I'm old enough to remember not having any treatments available for IPF or PPF, and so to have access to therapy has been incredibly beneficial. However, I think we have to be realistic and recognize that sadly the majority of our patients have continued to die from respiratory failure. So we haven't genuinely transformed outcomes with the treatments that have been available to us. And as everyone knows, using pirfenidone and nintedanib in clinical practice is often not straightforward, that many patients certainly struggle to take the therapeutic dose. Side effects are a common issue, and even patients who remain on treatment often struggle with, for instance, the diarrhea or the weight loss that goes with both drugs. So I think, first off, having a third available option, which almost certainly looks to be better tolerated than existing drugs, is very important. And I think, this is the first time we've seen a drug used in combination. I was involved in the combination trials for pirfenidone and nintedanib, and none of my patients could take the two drugs together for the 3-month durations of the study. So this is the first time we actually have a drug that realistically can be used in combination with existing treatment. And my expectation is that combination treatment is probably the way we will succeed in the future in better managing IPF. And so at the very least, that is now something we can consider in our clinical practice. And it obviously, I'm sure someone will ask the question, how and when are we going to use it in combination? But I think just having the option is very important.
Yeah, that question already came through, but I'll get to that in a moment. I want to just follow up on a point Justin brought up earlier on. I think, Justin, you mentioned that about the efficacy results, and that seeing these studies together separately can almost be overlaid on each other, and it's much more powerful that way. Is there any case to be made for pulling these studies together as progressive pulmonary fibrosis and being agnostic to the diagnostic labels? I mean, you've seen both results, and given your expertise in the field over time in PPF, do you think there's any value to that, or should we just stay away from that at the moment?
Yeah, I mean, I gave you know this as well as anybody, but I gave a talk at Pulmonary Fibrosis Foundation Summit about whether we should be separating IPF and PPF. And, I think we have an accumulating evidence base that suggests we probably don't need to. There might be some nuance still in those with autoimmune disease, but generally, if it's a lung dominant pulmonary fibrosis, then I think both trial data along with some of our molecular data suggest that we can probably treat them as one, which certainly could shorten the or reduce the size of clinical trials being done. These were two trials that were done in parallel with 1,200 patients each, and if you view them as the same process, that cuts down on quite a few patients needed to enroll. So I think there's considerations from the EMA, FDA, that sort of thing, that from what I understand still wants these diseases parsed. But Toby could probably speak to that better than me. But I think biologically there's a good rationale for combining the two.
Yeah, I mean, when you have a lung limited or lung dominant disease, then it might sound counterintuitive to just muddy the waters. But Toby, what do you think?
Yeah, I agree with Justin. I think we probably do need to be a little bit cautious with CTD-ILD. I think there are differences there, both from a molecular perspective, a pathogenesis perspective, and also a disease behavior perspective. But I think once you go beyond CTD-ILD, there's a huge degree of overlap in disease behavior, and certainly, all the evidence we've seen now with nerandomilast, nintedanib, pirfenidone is if you have an effective antifibrotic, it will work in patients who have pulmonary fibrosis. And historically, the only reason to separate out diseases is really just to simplify trial design. When you're running a clinical trial, you want to keep your population as homogeneous as possible. And with IPF, we've certainly had our sort of most or best defined patient cohort that is most homogeneous and predicts or behaves most predictably. But I think as we've done more trials in PPF, we can see that actually the whole group of patients behaves fairly predictably and in a fairly similar way. And it's probably a fairly artificial distinction between PPF and IPF, which is, after all, another form of progressive pulmonary fibrosis.
You see another form, and I heard it just last week that someone told me you believe primarily that you have IPF-like diseases and CTD-ILD-like diseases, and those are the two major categories. And you just sort of alluded to that again. When you were presenting the paper here, you showed, I think, the point that the majority of the fibroneer PPF or fibroneer ILD study were those with CTD-ILDs or autoimmune lung diseases. And so that brings me back to the question, that the point you made earlier on. You mentioned combination therapy. The question came in, why do patients without background antifibrotic therapy decline less? Or in other words, if I can reframe it, those on background antifibrotic therapy decline more. Why do we observe that sort of discrepancy in the results?
Shall I take that first? Unless Justin wants to restate what he said before. Yeah, it's an interesting one. I think I think it is a selection bias. So if you look at both studies, if you look at the IPF and the PPF data, the overall rate of FVC decline in the placebo group in the totality of the study is actually less than we saw before the advent of effective antifibrotic therapy. So that it's easiest to see in the IPF data. But historically, patients on no background treatment in IPF trials used to lose about 240 mils. In fibroneer IPF, the whole cohort only lost 180 mils, and that's consistent with what we've seen in other phase 3 studies. So antifibrotic therapy must be working on the whole because the rate of FVC decline in patient trials has reduced compared to before the advent of treatment. So I think that's the first thing to say. This is not a true failure of antifibrotic drugs. But I think what happens to lead to this paradox of less decline in patients on no background standard of care versus more decline on background standard of care is a selection bias. In general, if you're taking an antifibrotic drug and your disease has relatively stabilized, then you don't have an incentive to go into a clinical trial. And so I think naturally by recruiting patients into trials, we're recruiting patients who are failing treatment. And by the same token, our patients with the worst forms of fibrosis, with the most aggressively behaving fibrotic lung disease, those that are sort of losing, 10, 15, 20% of their FVC every year, they will move hell and high water to be on an antifibrotic drug. They will take nintedanib or pirfenidone, even if it's causing side effects, because they're so terrified of the consequences of not doing so. Patients who are not on background treatment, I think, are by their very nature a slightly self-selecting group of patients with more indolent disease, the patients who feel that the treatment is worse than the condition itself. And so I think we're selecting out patients with a milder disease trajectory. So that's my way of rationalizing it. It's a hypothesis, it's not proven. But I can't think of a better way to explain it.
I think that was very, very well said. Justin?
Yeah, I don't have much to add to that. I mean, I think selection bias is going to be our best explanation for this.
And that's selection bias at the level of the site PI, right? Where patients are being enrolled primarily, not overall in the central study.
Yeah. Who's going into the study? Yeah.
Yeah. So the other question or point that has been brought up is that in addition to the things that you mentioned, there may be some regression to the mean as well. Adherence differences may play a role in this, and that leads to the between group comparison becoming misleading. And so I think people have, statisticians who are much more smarter than myself have encouraged us to compare the within stratum groups to placebos as opposed to comparing across different strata. I think that seems to be much more savvy. Toby, you also mentioned earlier on that nerandomilast is well tolerated. And Justin said exactly the same thing. In fact, it's just recently been approved in the US here. How would the tolerability of nerandomilast impact clinical practice? Now, I know it's been approved for IPF, but thinking about PPF in particular, in identifying patients for treatment at an earlier stage, is there any hope that this will expedite early identification because there's a treatment available? And could it potentially even necessitate revisions to future PPF guidelines? I'll probably start with Justin and come to you, Toby.
Yeah. So, with tolerability in mind, I think the biggest driver of people not being on drug and us not impacting outcomes as much as we had hoped, as Toby said earlier, is that they're not going on drug, or their providers presume that they're not going to do well on the drug. And so there's this huge gaping hole in our field right now, which is, we've got drugs that work for the disease, but less than half of people are actually taking the drugs. And so this addresses that huge knowledge gap by essentially having a drug that there is no reason for a patient not to try and no reason for a provider not to offer. And so I'm hopeful that as that becomes more commonplace, that we actually will start to see some improvement in outcomes. And the regulatory authorities, I think, see that with the totality of the data too, which probably explains why it went through relatively smoothly in the US, when it could have had a lot more challenges. But that's my impression of where this comes in and how it's going to fit in our toolbox.
Yeah, I like the allusion to the right to try. I think every patient should be offered that opportunity. Toby, thoughts?
Yeah, I agree. I think that the tolerability challenges raised by pirfenidone and nintedanib have been a huge barrier to them being used widely. It's not uncommon to see a patient for a second opinion who's come in on oxygen. They're now in respiratory failure. They're now approaching end of life, and they tell you that they haven't been on an antifibrotic drug because their previous provider told them that the drug was worse than the disease itself. It has never made sense to me in a deadly disease, but that's a frequent, comment that I have heard. And I think, again, we all know from practical experience that when we prescribe pirfenidone and nintedanib, we very commonly get phone calls from patients. We have to offer lifestyle advice. And in an academic center where I've got a pharmacist and I've got nurses and I've got a dietitian, it's relatively straightforward for me to do all of that because I'm not having to do it myself. But if you're a single-handed provider in the community and you're fielding all of those phone calls and you've got to give all of that advice, then I can see why pirfenidone and nintedanib might seem like more hassle than they're worth, particularly as patients don't see any short-term gains in quality of life or symptom relief. So, as Justin has said, I think having a drug that can just be prescribed and then not have to be worried about thereafter should make life easier for pulmonary sort of community pulmonologists, and it should sort of remove that barrier for prescription that has been there with pirfenidone and nintedanib. So I like Justin, I'm optimistic that we might see a sort of step change in outcomes as more patients are actually both offered treatment and then able to stay on treatment in the longer term.
Yeah, those are very good points. I think as physicians, we always want to maximize the time we have with patients and bring more value to a broader group of patients. And so when we don't have to check LFTs and check CBCs and have to do all those monitoring things, it gives us more time to attend to a lot more patients than we normally would have with a few select number of patients. The other thing I'll point out is it seems that in this drug, the package insert has no section 5, so there are no warnings or labels. And what's not to love about that for a drug in patients who already have to deal with a lot already? There's a question, I think, Carla, you want to take that?
Yes, I think there's 2 questions from the audience. So the first is, how can we explain the mortality signal even after only 1 year on therapy?
Well, most of the deaths were respiratory related, and so it's I think we can assume that these were from progressive IPF and PPF. We did see with Ascend and pooled post hoc of nintedanib that there was a survival signal early, and we're seeing the same thing here. And just so happens that it's more pronounced than I think we saw with those other trials. So, disease modulation. Well, first of all, before disease modulation, we know that there's a lot of heterogeneity in the natural history of these diseases, and some are going to be rapidly progressive, and we know those patients typically will die in a year if they're rapidly progressive. And so, it stands to reason that this is blunting progression to a sufficient extent that those rapid progressors are not dying in that first year at least. And hopefully with the follow-up data, post-marketing, and even Fibroneer on that's going on right now, that will have more data that shows those survival curves continue to separate.
I think I just to add to that, one of the interesting observations is that when you look at the FVC data, we don't really see any difference between 9 and 18 milligrams if we account for the drug-drug interaction that occurred with pirfenidone in the IPF trial. But when you look at the mortality data and the secondary endpoint data, there does seem to be some additional benefit of 18 milligrams over 9 milligrams. And it's that difference in the secondary outcome measures that really has led the FDA to approve the higher dose of nerandomilast, because normally the FDA would approve the lowest efficacious dose. And so if you just looked at FVC alone, you would expect FDA to approve 9, not 18. But in actual fact, they approved 18 as the primary dose because of that survival advantage. And the reason, just to emphasize that, is it would suggest that some of the survival benefit is coming from something other than slowing FVC decline, that there may be some added benefit, whether that's on the vasculature or whether the proposed anti-inflammatory mechanisms of nerandomilast are actually important. But it is doing potentially something more than just slowing FVC decline. And I think, something for us to try and understand as time goes by.
Yeah, thank you for adding that, Toby. That's a question I've heard a lot of times. Why 18? Why not 9? I think, again, you just clearly outlined it's the totality of the data that's been considered, and that's what led to the FDA approval of the 18. There seems to be another question as well from the audience, Carla.
Yes, there's, I think, a couple more, but the next one is for each drug. I believe I've seen an initial increase in FVC, but eventually patients treated progress towards the status quo, at least in terms of outcomes. Any thoughts on trialing rotating antifibrotics rather than combining from the audience?
So that's my impression, is they were talking about the previously existing antifibrotics, right? So nintedanib and pirfenidone tend to regress towards the mean eventually, even after increase. So
that's what they mean.
Should we think about trialing both medications, rotating both medications, all 3 medications? And it's a very complex question, but I would defer to the experts to answer that.
I too will defer to Toby.
Anyway, I think it's a good question. I think, as I alluded to earlier, for the first time now, we do have the potential option to consider combination treatment. There's only ultimately so much information that we can derive from the current trials. Essentially, these were done as add-on to existing therapy, whatever that therapy might have been. And so it gives us some information about combination treatments, but it really doesn't tell us how to optimize them. Should we go for early upfront combination? Should we wait for treatment failure? And what is treatment failure before starting combination treatment? Should we, as you've said, cycle treatments, although that seems a little bit complicated and challenging. But I think, we need to be thinking about the trials that we need to do going forward to give us the evidence base to support any one of those strategies. And I think it's, it's a good problem to have, but we really do need more data to provide anything other than my own expert opinion. And even then, it's, how expert can it be? I've prescribed it to a handful of patients, so it would be anecdote at this stage to try and suggest a knowledgeable answer to that question, but we really do need to generate data.
And it's not just 3 drugs, right? We'll soon have 4, most likely. And so, comparative effectiveness trials, I think, are going to be very hot coming up. And I know the PFF is pushing for that. And I think that'll be very helpful for the field.
Yeah, hopefully more than even 4, given the plethora of studies out there. So we're very hopeful we'll have a lot more trial therapies in the future. One question I think from my end that came as well is there seems to be a signal towards patient-reported outcomes in this trial, where we saw with I think it was a Fibroneer IPF study, a delay in the need for supplemental oxygen for patients in the treatment arm that was different from those in the placebo arm. And I think once we get over our philosophical stumbling block of statistical nuances for any study, it really boils down to what patients really want. How do they look? How do they feel? How do they function, right? No patient have ever came to me and say, I want my FVC to be 100% when it was 90%. They want to feel their cough has gone away, their symptoms are better, their shortness of breath is improving. And so when we look at this in the context of endpoints, is this beginning to redefine how we think about clinical trials in pulmonary fibrosis? Should we lean much more on patient-reported outcome measures for aiding those endpoints that are meaningful, so that patients also feel some benefit in terms of symptoms from the drug they're being given? What are your thoughts about this?
Yeah, I can take the first stab. While we all know the importance of quality of life measures, those don't seem to move a whole lot in clinical trials. InBuild, I think maybe was the exception there, but with the Fibroneer IPF trial, and I'd have to refresh my memory on the PPF, but there really was no difference in quality of life measures between the groups to speak of. You did mention supplemental oxygen need, which is interesting. At least through 12 months, there did seem to be a lower rate of new supplemental oxygen prescriptions compared to placebo. So that's a very important quality of life measure there. It kind of dissipated after 12 months, but so while we can't say that there's a reduction in supplemental oxygen need, as you said, there might be a delay, which is important too. But I struggle with how we will incorporate quality of life measures as a primary endpoint in these trials, just because this tends to be a one-way road, and getting people to feel better is really a challenge. And so I think getting them to have less loss of lung function, survive longer, is a great starting point, and hopefully we can find something that also helps quality of life. But it's hard when it's not a particularly reversible process.
Yeah, it's a very pragmatic answer to a difficult question. Toby?
Yeah, we don't have Jeff Swigris here, so we can be as rude as we want about quality of life tools. I think the challenge is how we measure quality of life. It's a tricky concept. I know all of us from our own lived experience have a vision of what a good quality of life is for us, but what you need for that quality of life depends on whether your passion is playing golf, sailing, or perhaps just watching films and reading books. And added to that, one of the major challenges with these tools is that we are trying to run international multi-center studies, and questions that make sense to an American patient about impacts on quality of life might not make sense to patients in China or Japan or South America. And so I think the real struggle has been developing ways of consistently measuring the impact of disease on individuals. Because when you dig into the quality of life data in the Fibroneer trials, you see there's actually very little change in quality of life in the placebo group. There's very little impact, in actual fact, of the disease on the quality of life tools at baseline in the placebo group. And so that suggests to me that the reason we're not seeing any differences is because we're just not able to get at the question in a granular enough way to then be able to tease out what treatment may or may not do. And I don't have an answer as to how we do that. Jeff Swigris has spent 20 years trying to think about it and has done a lot of hard work in this area. And even now, we're struggling to move things forward. So it remains a challenge, and the oxygen use is maybe a surrogate for quality of life, because we certainly know in the journey of a patient with the disease, initiating oxygen is an important, is a change. And it's a change that comes with a lot of psychological baggage and impact. So maybe the oxygen use is a way of teasing this out in the future without having to rely on sort of multi-pronged questionnaires.
Very eloquently stated. I think it's hard to top that. Well, we're at the top of the hour. Actually, we're a minute over the hour. I'm going to take a few moments to quickly wrap things up. And given these remarkable publications we've had, we expect to see a lot more progress along how we care for elderly patients over the next decade. We've started to see that in practice already with IPF. I want to very specially thank Dr. Oldham and Dr. Maher for putting together a fantastic presentation. And very special thanks to my wonderful panelists, Dr. Copeland, for additional insights and helping with fielding questions from the audience. Once again, we're grateful to Daniel Robledo for facilitating this Journal Club webinar. I thank Carla again, in particular, my Journal Club co-editors and other members of the Clinical Problems Assembly who helped put this Journal Club through. Finally, thank you to the audience for your participation today. Thank you all and have a beautiful rest of your day.